trying to propose a series of mechanisms, firstly to reduce demand on A&E, and you've alluded to that, and then the second thing is to provide those people with serious conditions with the very best treatment. This has been described as, on the one hand, a two-tier system, on the other hand, downgrading, if you like, of a lot of A&Es. This is complete nonsense. What we're really describing is what is already happening. So if you have major trauma, if you have a major heart attack, or if you have a stroke, in most metropolitan areas, we already have centres that are designated for dealing with those that have the best clinical teams, clinical expertise.
So you'll be driven past a smaller hospital to go to the place where they can cope with you if you've got something very serious.
Indeed, that already happens.
Yeah.
Let me give you an example with trauma. So a couple of years ago, we designated 25 trauma centres across the country, and we said ambulances will only take serious trauma cases there, because many A&Es were only dealing with one trauma case every 2 weeks. The naysayers said, well, of course, there'll be problems with travel time, and it's going to put patients' lives at risk. In the first year of operation, we've seen a 20% increase in survival for equivalent injuries. And similarly in London, when the number of stroke centres were reduced from 32 down to just 8, we've seen a vastly increased survival, more patients returning to independent living, and actually it's savings to the NHS.
How important is it to stop people going to A&E who think they need to go, but actually don't? How many people come away without having been treated?
Well, about 40% of people don't need any treatment. They simply need reassurance. So one of the things we're going to do, which I know some people find a bit controversial, is we're going to beef up, or we're proposing beefing up the 111 system. So what patients have told us about the 111